I'm Dr. Phil Pickett, veterinary ophthalmologist at the Virginia Maryland College of Veterinary Medicine at the Virginia Tech campus in Blacksburg, Virginia. Today we're going to be working in the field at a veterinary practice, Cave Spring Veterinary Hospital in Roanoke, Virginia. Today we're going to be doing ophthalmic diagnostic techniques that the general practitioner or the student would use to examine the eye of a dog. Instrumentation that we're going to use today is going to be instrumentation that the average veterinarian would probably have in their clinic, as well as we will show instrumentation that one would use if one had state-of-the-art equipment. We're going to be using tonometry to measure intraocular pressure in the eye. We're going to be using a rebound tonometer, the iCare TonoVet Plus. We're also going to be demonstrating the TonoPen, which is an applanation tonometer that's also used in practices. We will be using the direct ophthalmoscope, and we will show you how to use all the different light settings as well as the diopters to do a full examination using this one simple instrument. We will also be using the otoscope to show how to utilize this piece of equipment for examination of the external eye and the anterior segment. Other techniques that we will be doing today will be the technique of indirect ophthalmoscopy, a technique utilizing a hand lens to examine the posterior segment, the fundus, of a patient. Lastly, we will be discussing the concept of slit lamp biomicroscopy, the utilization of a slit beam of light angulated from the line of sight of the examiner to adequately be able to identify structures and where they are inside the animal eye. Finally, we will be doing some diagnostic and therapeutic techniques such as looking behind the third eyelid using a forceps under topical anesthesia, Schirmer tear testing, and other techniques as well. I hope that you'll follow along as we go through this diagnostic process. Let's get started. The first portion of the ophthalmic examination is the gross examination. At arm's length, you'll be looking at the patient's head, looking for symmetry. It's very important that you put your patient at your eye level. The oculocephalic response in dogs, when the head is torqued up, they tend to seek the horizontal. So if I'm standing looking down on the patient, then I'm not going to see the ventral portion of the head. So the initial examination is basically looking for symmetry. Is there any ocular discharge? Is there a mucopurulent discharge, a sanguineous discharge, a serous discharge? You can gently roll the lids up and look at the bulbar conjunctiva. You can retropulse the globe and see the third eyelid. These are all the things that you'd be doing with the gross physical examination. It needs to be done in a well-lighted area. So following the external examination, then we will move on to the second portion of the ophthalmic examination, where we do a detailed external ophthalmic examination using magnification, some sort of light for illumination purposes. So the next portion of the ophthalmic examination is the detailed external ophthalmic examination. For this, you're going to need to have a technician or an assistant restrain the patient so that you can use both hands in your manipulation of your light source and your manipulation of the external ophthalmic structures like the lids and the third eyelid. I tend to use a focal light source. A Finoff transilluminator works very well. Sometimes some of the little small pen lights that people have work well. They're not quite as bright. Or you can use the round aperture lights from the direct ophthalmoscope. As far as for magnification purposes, if one is older and is presbyopic, using the bifocal portion of your glasses works. Other techniques that people use are to simply go and purchase a set of 3 diopter reading glasses. The 3 diopter lens is going to focus at 1/3 of a meter, which is about 13 inches. The closer one gets to what you're looking at, to the eye in this case, the more magnification. And since small things are very, very important in ophthalmology, the closer you get, the more magnification, the more likely you are to pick up a lesion. Another source of magnification that is commonly available by practices is the OptiVisor, or some sort of simple lens system. This particular one is a 5 diopter, so the 3 diopter would focus at 1/3 of a meter, which would be about 13 inches, and the 5 diopter would focus at 8 inches, or 1/5 of a meter. They do make fancy ophthalmic loupes. These are a set that I've used for many years. They are 4.5x magnification, and they are set for me to use at a working distance of 16 inches, which for me with my long arms is a very comfortable distance to work when I do surgery or do an examination. I'm going to start my examination by strictly turning the light on and looking at the reflection from the back of his eye. This is looking for the tapetal reflection, and I'm going to look at it in both eyes. Now we will talk about the neuro-ophthalmic examination, the pupillary light responses, in a moment. Then I'm going to move my light source so that my light source is at a different angle than I am actually looking at the patient. This allows me to judge a little bit of depth. We're going to talk about using a slit beam pen light in a moment that allows you to see even more depth and judge where things are in the eye. And then I may actually have the light shining straight on, and I actually look at it from the side, once again giving me a little bit more of a three-dimensional appearance. An underutilized technique for doing external ophthalmic examination, the detailed external ophthalmic examination, is utilizing the diopter settings on the direct ophthalmoscope or utilizing the 10 diopter lens in a veterinary otoscope. So if I'm going to examine the surface of Prince's eye here, I'm going to put it on a +10 diopter, which is going to focus at 1/10 of a meter, which is approximately 4 inches. Once again, the closer I get to the patient, the more magnification and the more I can actually see. So I have large hands, and in this particular case I'm going to hold his lids open myself, and I'm going to use my right hand to hold the instrument to look at the left eye, and I'm going to use my left eye to look at his left eye. So this is what we're going to do. I'm going to place my hand on the patient's zygomatic arch. I'm going to shine the light in his eye, and I'm going to drop my eye down, and I'm going to be able to see with magnification from the scope the surface of his eye. I'm going to look for blood vessels. I can look at the surface of his iris, and if I need any fine adjustment as far as focusing, I can just weave and bob in and out until it's actually in focus. If I'm going to look at the right eye, I'm going to hold the instrument with my left hand, and I'm going to put my finger on his zygomatic arch, and I'm going to use my right eye, so right to right, left to left. Now if I was going to use the otoscope, the veterinary otoscope, because veterinary cones are 4 inches long, is going to be a 10 diopter. It's going to allow me to look at surface structures from 4 inches away. And so the same principle. I'm going to have the lens in place, basically going to look at the little guy here, and I'm going to get close just like I'd use it to look at the ear, and then I'm going to go to the other side, switch my hands, and do it again. Following the detailed external ophthalmic examination, we would like to test the tear production, the aqueous tear production in our patient. This is accomplished by using what's called a Schirmer tear test strip. These particular models have a dye, a blue dye. This strip is in place for 60 seconds. In human beings, it's in place for 5 minutes. So basically what we're going to do here is take these out of their little packet, and then we're going to place it with the rounded tip in the cul-de-sac. So I'm going to basically roll Prince's lid down so you can see his inferior cul-de-sac, and then I'm just going to drop it in. Normal tear production in a canine patient is going to be approximately 15 millimeters of migration of the tear film over the piece of paper or above. Anything less than that is concerning that the patient is not making enough aqueous tear and keeping their eye properly moisturized. The cat normally would have about the same tear production as the dog, but it's very common for cats to become excited and the tear production be decreased. It's not uncommon if you have a really scared cat to have a Schirmer tear test value of 5 or 6, and yet the patient is perfectly normal. Following measuring tear production in the eye, we want to measure the intraocular pressure in the eye. The intraocular pressure is important because low intraocular pressure could indicate an inflammatory process in the eye called uveitis. Normal intraocular pressure in the canine patient is from 10 to 25 millimeters of mercury pressure within the eye. And elevated pressure within the eye is a disorder called glaucoma, which can be painful and can be blinding. One of the ways to measure intraocular pressure is using a rebound tonometer. This is the iCare TonoVet Plus rebound tonometer. The principle behind this unit is the use of a magnetized pin that has a plastic tip to it, and this pin is placed in the instrument and then it is shot out until it hits the eye. If you think of the principle of dropping a golf ball onto a hard floor, if the surface is hard, the golf ball decelerates quicker and bounces higher than if you dropped it on a pillow. So basically what we're going to do here is we're going to take the protective tip off. We're going to drop this in sterilely. Following loading of the magnetized pin, we want to first make sure that we're testing the canine patient. This unit is calibrated to take pressures in horses, dogs, cat, and rabbits. So in this case we have it sitting on the little dog icon, and so we're ready to go. Notice how the instrument has a light source here at the front. It tells you if you're holding the instrument in the proper alignment. If I tilt the instrument up, when it rebounds it's actually working with gravity, which gives you an erroneous reading. And if I tilt it down, then it will also work against gravity and give you an erroneous reading. I can rotate this instrument. I can either hold it straight upright or I can actually rotate it depending on the shape of the patient's head, just as long as I keep the pin parallel to the floor and the light maintains its green color. So once we have placed the pin in the iCare TonoVet Plus, put the unit close enough to the eye that when we push the activating button on the back, it will shoot out and touch the cornea and rebound back to the instrument. You can do this with individual readings. Basically it takes 6 readings and averages them, throwing out the high and the low, and this gives you the mean reading for the intraocular pressure. Alternatively, this unit is calibrated so that one can push the button and hold it down and it will automatically shoot the pin out on its own. Basically, you can see that he did not wince, blink, or anything else because this is such a light touch that most patients do not feel it at all. Another technique for checking intraocular pressure is called applanation tonometry. Applanation tonometry is accomplished using a TonoPin applanation tonometer. This is a human instrument. This type of tonometry requires that we touch the cornea a little more aggressively, and so for this purpose we have to use topical anesthetic placed on the eye. We tend to use 1% proparacaine, and basically we're just going to tilt his little head up, roll his eye back, and we're going to dive bomb him with the drop onto the surface of his eye. It takes approximately 30 seconds for the surface of the eye to become numbed. Proparacaine lasts for approximately 10 minutes. Realize that topical anesthetic is not to be used as a therapeutic drug because repeated applications over a long period of time, say for a day or so, can actually slough the corneal epithelium, causing a corneal ulceration. So the TonoPin is an instrument that works on the principle of when you flatten the surface of the cornea by pushing on it with this instrument, there is a transducer that reads how much pressure the eye pushes back against the instrument. Because the tear film has salts and stuff that can actually clog this transducer, we use little tiny latex covers that covers the tip of the unit so that it doesn't get into the instrument and foul the mechanism. You want to make sure that the tip is on tight enough that it is not bulbous and you can actually see that the tip is touching the eye, but you don't want to have it so stretched that it actually gives you erroneous readings. One has to develop the touch to get good readings. Not too hard, not too quick. There is a fairly steep learning curve compared to the other tonometer. So what we're going to do with little Prince here, we're going to turn him around, and you're going to see how I touch this eye, and every time I get a reading, it clicks. And when I get enough readings, it will average the readings and give me a digital readout on the intraocular pressure, and it will also have a line underneath that will be percent error. So following checking intraocular pressure, we're going to dilate the pupils so that we can examine the deeper structures in the eye, the lens, the vitreous, and the ocular fundus. The reason that we want to measure the intraocular pressure prior to dilating the pupil is because in dogs, if you have a patient that has angle closure glaucoma, and if their intraocular pressure is elevated, dilating their pupil can actually make the pressure go higher and be more problematic for the patient. The drug that we're going to use is tropicamide. Tropicamide takes effect in about 20 to 30 minutes in most patients. It only lasts 3 to maybe at the most 8 hours, especially in cats. Sometimes it'll last a little bit longer than in dogs. So we're going to use our tropicamide to dilate his pupils here. I'm going to tilt his little head back here, and then we're going to allow the drop to fall onto his eye. If we touched the tip of the dropper bottle to his tear film or to his surface of his eye or even his skin, what could happen is as we release the squeezing tension on the bottle is it actually can suck it back up, contaminating your bottle with any kind of bacteria, virus, or anything else that might be on the surface of this particular patient, and then you pass it on to everybody afterwards. So once the pupils are dilated, we can examine the structures behind the iris, the lens, the vitreous, and the fundus, or the retina, as most people refer to it. What we're going to do first is use our direct ophthalmoscope, and we're going to do a technique called retroillumination. And this is the same as backlighting. When I shine a light into the eye of most animals, you will see the reflection come back from their tapetum, the reflective layer on the back of their eye. Anything that is between the back of the eye and me will be backlit. And in this case, Prince has some early cataract formation. He's 14 years old. He has just basically old dog cataracts. And so when we evaluate the reflection from the back of his eye, instead of being totally clear, dark areas of shadow where the lens is opaque and the light cannot penetrate through. So instead of seeing a nice clear shiny tapetal reflection, it's a mottled tapetal reflection because of the lens. So this is an excellent technique for looking at opacities of the media in the eye, whether it's the cornea, which is in front of the iris, it's in the anterior chamber fluid, which is in front of the iris, or after you've dilated the pupil, it's in the lens, or even if you have foci of opacification in the vitreous chamber itself. In human medicine, we refer to these as floaters. They're basically suspended material, cholesterol, whatever, in the vitreous humor. So what I'm going to do here is I'm going to take my glasses off so that I can get my eye closer to the scope itself, and I'm going to put my the brow piece, the little rubber part, actually on my brow. Since I'm going to work at about 20 inches, which is a half a meter, I'm going to put it on the +2 diopter setting. And that way, even without my glasses on, I will be able to focus on his eye using the instrument. So normally we would do this in the dark, but you wouldn't be able to see it very well while we were doing this. So I'm going to sort of stage this, and you'll see how I'm going to do this and the distance that I'm going to use to adequately use the tapetal reflection to see opacities. So we're going to get Prince to look right at me here. Once again, we need to be about at the same level as he is, and so I'm going to get him to stand up here. Atta good boy. Atta good boy. And then I'm basically going to look here, and I'm going to shine the light right in his eye. And if I want to look at different areas, I can move around and see different areas of opacification by just moving him around. All the while, I am using the reflection from the back of his eye, which in his case is a yellow-green color. And then if I want to look at the other eye, I can either change hands like we did before and stand back and look again. Okay? And so I'm going to weave in, and it's going to be a little bit out of focus, and I'm going to weave back, and it's going to be in focus, and I'm going to back off just a little bit, it's going to be out of focus. So basically whatever you set it on, and you weave and bob until you're in good focus, is how you're going to work this thing. If you're young and your own eyes have the ability to accommodate for near and far vision and everything, you don't have to do this. But once you get past 40-something and you have presbyopia, unless you're wearing your corrective lenses, you're going to have to do a little weaving and bobbing. So the next technique for examination of the internal eye is called slit lamp biomicroscopy. For demonstration purposes, we are going to have the lights dimmed for the next two techniques, or three techniques, direct ophthalmoscopy, indirect ophthalmoscopy, and slit lamp biomicroscopy. Anytime you're trying to look at the internal structures of the eye, you have to look through the cornea. And if you have overhead lights on, if you're looking at an animal outside, you're going to have reflective glare off the surface of the cornea. So these techniques are best done with the lights totally out, with only the illumination from the instrumentation that you're using shining into the eye. And slit lamp biomicroscopy is use of a microscope for magnification and an adjustable light beam that is a slit. This allows you to judge where something is in the eye based on the light passing through the cornea, that is the first interface, passing through the anterior lens capsule, that is the second interface, going through the lens itself, and then as it exits the posterior lens capsule, the third interface. These three interfaces are called Purkinje images. So if you are looking at an object in the eye, say you have a blood clot in the anterior chamber between the lens and the cornea, you will see the red object in the anterior chamber, and it will be between the first beam on the cornea and the second Purkinje image on the anterior lens capsule. If you're looking at a cataract, an opacity of the lens itself, then the opacity will be highlighted between the second beam and the third beam, which is the deeper beam, and that's the posterior lens capsule. So using this relatively expensive piece of equipment, basically what I'm going to do here is get his eye open. I'm going to shine the light in his eye. I'm going to drop my eye into the eyepieces, and I'm going to look at his eye. And so that's what slit lamp biomicroscopy is. And in veterinary medicine, we tend to use what some people call pediatric slit lamps, handheld slit lamps. Some people like to just say, well, they're veterinary slit lamps, okay? But they're used a lot in human medicine as well. Now let me show you some techniques that you can do with instrumentation that you have at your own availability, okay? So we talked about using the simple lens system for magnification, the OptiVisor or the glasses. All right, and so what we're going to do here is we're going to use one of these to see close up, innately see magnification, and then we're going to use the slit beam from our direct ophthalmoscope. So I'm going to turn this on, and you can see the beam on my hand, okay, and that's going to be your beam of light as if you were using a slit lamp biomicroscope. I am going to direct the beam at an angle different than what I am going to be looking at, and this is going to give me the three-dimensional effect that the slit lamp biomicroscope gives you, which is what we're wanting to see, is where something is in the eye. So we're going to stabilize his head here, and I'm going to come in, I'm going to look at it from the front, and I'm going to shine the light from the side. Did you sneeze, buddy? Okay, or I could actually shine the light from front, and I could come over here and I could look at it from the side this way. Okay, both ways I'm shining the light at a different angle than what I'm looking at. Now, they also actually make little tiny slit beam pen lights just for this purpose. And so I can do the same thing, as I can shine this light in and see, either shining it from the front and then I look at it from the side, or I shine it from the side and I look at it from the front. This is where it is very beneficial if all the lights are turned out. For this demonstration, we have lights on so you can see where I am and where Prince is. But reflection off of the surface of the cornea from overhead lights, backlights, whatever else, is going to cause deterioration of the image that you're trying to see. So this is a technique that is best done in absolute darkness with just the light of your beam as your illumination of the eye. The technique of direct ophthalmoscopy we touched upon earlier when we talked about how to use the diopter settings on the direct ophthalmoscope to look at objects close up. So now that we've dilated the pupil and we're going to be looking at the lens, the vitreous, and the fundus, we need to understand a little bit more about how diopters work in the eye. The eye is an optical system. Light from infinity, unless the dog or the cat or the horse is nearsighted or farsighted, which is pretty common in human beings, is going to focus light rays on the retina. And so what I'm going to do is I will use the direct ophthalmoscope on a zero, infinity, to focus on the back of the eye. So we earlier said that from 2 inches away, the surface of the eye would be in focus at 20 diopters. And if the back of the eye is in focus at 0 diopters, then everything else falls in between. So what I'm going to start out with here is I'm going to look at the surface, the anterior surface of Prince's lens using the 10 diopter setting on my ophthalmoscope. When I click it to 8 diopters, it will be in focus on the back of the lens, and as I go from 8 diopters finally to 0, the back of the eye, the retina, the optic nerve, the vessels, the tapetum will come into focus. I'm going to use my left eye to look at his left eye. I'm going to use my right eye to look at his right eye. I'm going to want to be as close as I can to his eye to see things, because that will negate the corneal curvature. Plus, I always like to use the example of looking at a baseball game through a knothole in the outfield fence. The closer you are to the knothole, the more the field you're going to see than if you're standing further back. Okay? So I'm going to basically turn this on. I'm going to put this on my hand on his zygomatic arch like we did before. I'm going to turn the light down so it's not quite so bright. And I'm going to start at 10. And I'm going to be able to focus on the surface of his lens capsule, the front. And then I'm basically going to dial it down a little bit to a +8. And now I'm in focus on his cataract on the back of his lens capsule. And I'm going to keep going down. I'm just going to go ahead and go all the way down to 0. And now I am able to see the back of his eye, see his optic nerve, see his retinal blood vessels, and everything else. And if I move around, I can see the different areas. I'm down looking up, I'm up looking down, and if I'm going to switch over to the other eye, I'm going to do the same thing. Shine the light in his eye, and I'm going to use my right eye to right eye, and we're going to look at his eye and see the back of the eye. And so that's the technique of direct ophthalmoscopy. Now, as veterinarians, we like to see the whole panorama, and the images shown will show the image with direct ophthalmoscopy is very, very magnified in a very small area. Think of looking at an object with a pair of binoculars. The next technique we're going to talk about is indirect ophthalmoscopy using a hand lens at arm's length, and that's going to allow us to see the panorama, which for us as veterinarians is actually more important than seeing a lot of detail. The other technique utilized by veterinarians for examining the posterior segment of the eye, the back of the eye, the fundus, is the technique using a hand lens and a light source called indirect ophthalmoscopy. This technique, unlike direct ophthalmoscopy, is best done at arm's length. And this has its advantages in veterinary medicine because your face is not right next to the dog's mouth if the dog gets aggressive, and you are able to work at a little bit more comfortable distance instead of being right in the patient's face. So I'm going to start by using the high-dollar indirect ophthalmoscope and lens, but then we will show you how to use the technique or the instrumentation that you would have available to you in your practice to do this very important technique. So I'm going to basically put this thing on my head. And so this is a an instrument that has a light source that is coaxial to where I am looking. Just like the direct ophthalmoscope, I'm looking literally through the light utilizing a beam splitter. I'm going to be working at arm's distance here, and I'm going to get a good reflection. Notice how you see the beam of light on the patient's eye. And this is going to be important when you are using your own light to get the reflection from the back of the eye, when we already talked about the tapetal reflection, and then you're going to place your lens, your condensing lens, in front. The condensing lenses that we use, you can use very expensive lenses, or you can also use a condensing lens, a very simple condensing lens like we were talking about earlier. I think these things cost about $10. You can buy them at a hobby shop. They're used for, looking at stamps or insects or something like that, but you can do the same thing. There are a number of different lenses as far as the diopter setting, and each has its own benefit. I have a range of lenses that goes from 15 diopters up to 30 diopters. And so this is a 30 diopter lens. It's a small in diameter. The plus for using a higher number or a higher diopter is you see a wider panorama, but you actually see a smaller image. So it's always a trade-off. Too much magnification and not enough panorama. Too much panorama, not enough magnification. So the first thing we're going to do here is we're going to get our alignment. And if you'll imagine that there is a stick coming from Prince's eye and going directly through my instrument and into my eye, that's the proper alignment that you want to do this technique. Along that stick, you're going to place your condensing lens so that you can see through the condensing lens the image in the back of the eye. Now, when we looked with direct ophthalmoscopy, as I said before, we're really close, and we're going to see a very small area that's going to be very, very magnified. Okay, with this, you will see a lot larger area. Maybe, depending on which lens you use, maybe 30 or 40 times the area at much less magnification. The magnification may only be 1.5 to 2x of what you would see if you just look directly into the eye. Whereas with direct ophthalmoscopy, the magnification is about 10x. So you kind of get a feel for the magnification difference there. Okay. Now, notice that the light is on the surface of Prince's eye, and that's important. If I have my light directed to the wrong side or not directly into the eye, I'm not going to see very much. And so when I improvise by using other equipment as my light source, which we'll do in a second here, it'll be important to realize that you have to have the light shining, and it has to be reflecting from the back of the eye. So in this particular case, I'm going to line things up. You can see the light on Prince's eye, and you can see the beam of light on his cornea there as I beam in and I'm looking. You control the focus by literally moving in and out, okay, moving the lens back and forth like you would with any lens. All right. If I want to see the top of his eye, the pivot point for my stick is in Prince's eye. And so what I'm going to do, if you think of spokes on a wheel and the hub of a wheel, is Prince is the hub, and I'm out here on the spokes, and if I want to see the top of his eye, I get down and look up. If I want to see the bottom of his eye, I get up and look down. Same thing for left and same thing for right. The image you are seeing is going to be upside down, right is going to be left, and left is going to be right. And that's called a virtual image. And that's what you see when you do it with indirect ophthalmoscopy. You cannot get close enough to the eye to actually see the direct image that you do with the direct ophthalmoscope. So those are some really big principal differences between this technique and the direct ophthalmoscopy. Enhanced panorama at the cost of decreased magnification. You're working at an arm's length as opposed to working really, really close to the patient. And you have a much wider view. And the other thing with this is you can actually see through density better than you can with the direct ophthalmoscope. Because of the less magnification, even with Prince's cataractic lenses, I can clearly see the back of his eye. So now I'm going to show some ways that you can improvise and see what you can use with things that you would have in your own practice to do indirect ophthalmoscopy similar to how I did it with the expensive instrumentation. So as a light source, what I've got here is a single light headlamp. The fancy 4-light LED lights that cost a lot of money actually are not as good as the single light. And that's going to be my light source. And I'm going to bring it down as close to my eyes as I can get it, because I want coaxial illumination that's going to go through my eyes and through the lens and through his eye. Next, I'm going to use some reader glasses simply because I can't see up close anymore. So you could, if you're like me and you're going to be working at a half a meter, then you would want the 2 diopter reading glasses. So that's what I've got here. I'm going to put these on. And basically I'm going to line things up just like I did with the other, and I'm going to get the reflection from the back of Prince's eye. And then I'm going to take my lens, and then you're going to basically drop it in place, and you're going to see the back of his eye just like I did with the other instrument. So depending on how much you spend for the lens, whether it's $10 or $400, you may have a little bit difference in the quality of the image. But here I've got a $10 lens, I've got a $10 light source, and I'm actually able to do this technique quite well. So there's another technique that you have seen people probably use, and this is using a light source, either the transilluminator, the Finoff transilluminator we used before as your light source, or using your direct ophthalmoscope head. If you use a Finoff transilluminator, it is very, very commonly done by my students that they will be shining the light in the patient's eye, and by the time they line everything up, the light is not shining on the eye anymore, and they wonder why they're not seeing anything. So this is why I have my students use the direct ophthalmoscope. Because when I'm using the direct ophthalmoscope, I can see the beam of light. It's a much more focused beam of light. And so when I'm looking at this, you need to hold his little head up just a little bit there. Thank you. And I'm looking through my eye, and I'm actually able to see the reflection from the back of his eye here, and you notice that the light is shining on his eye. If I'm shining it away, it's very obvious I'm not doing it right. So this instrument actually makes you do the right alignment of the light source. So what we're going to do here is you're going to hold his little head up a little bit. Can you just gently hold his lids open? Because I'm now using both hands to hold instruments, and I can't really open his eye. So I'm going to get the good reflection from the back of the eye, and I'm going to put my lens in there, and I'm going to be able to see the back of his eye just like I did with the high-dollar piece of equipment. I've got this turned on a 2 diopter, just like my reading glasses, so that I can actually focus on the lens. And so these are the techniques that you can do to improvise and do a good fundus exam using a hand lens and using some sort of a light source. The final technique that we're going to demonstrate is the technique of looking behind the third eyelid. Sometimes you'll have a patient that will be very painful, and they may have a foreign body behind the third eyelid. Follicular conjunctivitis or follicular hyperplasia is best seen looking at the bulbar surface of the third eyelid. So we need to be able to do that. Since we are going to be actually manipulating the third eyelid, we need to use our proparacaine to numb the surface of the eyelid so that the patient does not feel this. So I'm going to apply my drop here, being careful not to contaminate. We're going to wait about 30 seconds or so. The forceps that I'm going to use is a rounded tipped forceps. It has no teeth, basically just has serration, so there will be a little bit of grip. Even with topical anesthetic, if you put a lot of pressure on the third eyelid, the patient will feel this. So you have to be gentle with this. So we should have had enough time here for Prince's surface of his eye to be numbed. And so what we're going to do here is she's going to manipulate the head, and I'm basically going to push the upper lid up and the lower lid down, and you can see the third eyelid come up as I move and push the eyeball back in the socket. And what I'm going to do is I'm going to reach in and grasp the third eyelid, and I'm going to pull it out and look behind it. Okay? And you look on the front of it as well, release. And so this is the technique of looking behind the third eyelid using a blunt tip forceps. So in summary, I hope that you have enjoyed and learned something from this videotape on how to do an ophthalmic examination on a canine patient using materials that you have available to you in your veterinary practice. I'd like to thank iCare for the use of the iCare TonoVet Plus. I'd like to thank my 14-year-old beagle dog Prince here for being such a good sport and letting us show you how to do an ophthalmic examination on a canine patient.